Good day. Today I am discussing fractures. Musculoskeletal trauma involves injury to one or more of the following structures. The bone is a unit of the skeleton composed of the hardest variety of connective tissue. Bones give shape and support to the body. In addition to surrounding and protecting vital organs, they serve as points of attachment for the muscles of the limbs, making movement possible. A joint is the area where two or more bones articulate with one another. Joints are usually classified in terms of the amount of motion permitted at the articulation. Most joints of the extremities are synovial joints, which allow the greatest amount of motion. Ligaments are bundles of connective tissue forming part of the fibrous capsule surrounding a joint and attached to it. Every joint of the extremities is reinforced by two or more ligaments, whose purpose is to stabilize the joint by confining its movements to specific planes and preventing movement beyond physiologic limits. Tendons are the fibrous structures that connect a voluntary muscle to the bone, cartilage, or ligaments. Tendons enable muscles to effect motion in the joint or body area to which they are attached. Orthopedic injuries to these structures include the following. Fractures are a disruption of bone tissue. Fractures may be caused by an application of force exceeding the strength of the bone, repetitive stress, or an invasive process that undermines the bone's integrity. Dislocation is the complete disruption of a joint such that the articular surfaces of the bones that comprise the joint are no longer in contact with one another. Subluxation is partial disruption of a joint in which some degree of contact between the articular surfaces remain. Fracture dislocation or fracture subluxation is disruption of a joint combined with fracture of at least one of the bones involved in the articulation. Strain is a tearing injury to muscle fibers resulting from excessive tension or overuse, and sprains are tearing injuries to one or more ligaments of a joint which occur when the joint is forced beyond the limits of its normal planes of motion. Proper assessment and treatment of bony injuries in the emergency room requires an understanding of the physiologic process by which fractures are created and by which they heal. The common types of fractures are quote-unquote common fractures, which are the result of significant trauma to healthy bone. The bony cortex may be disrupted by a variety of forces, including a direct blow, axial loading, angular or bending forces, torque or twisting stress, or a combination of these. Pathologic fractures are those that result from relatively minor trauma to diseased or otherwise abnormal bone. In such cases, a pre-existing process has weakened the bone and rendered it susceptible to fracture by forces that under normal circumstances would not disrupt the cortex. Common examples of such injuries are fractures through metastatic lesions, fractures through benign bone cysts, and vertebral compression fractures in patients with advanced osteoporosis. Numerous other disease processes may render an individual susceptible to pathologic fracture. Because these injuries often are not associated with a history of significant trauma, subtle pathologic fractures may go undetected unless there is a clinical index of suspicion. Bone may undergo a fatigue fracture or a stress fracture by being subjected to repetitive forces before the bone and its supporting tissues have had adequate time to accommodate to such forces. An example is a metatarsal shaft fracture in unconditioned foot soldiers, also known as the March fracture. Radiographs often are negative early in the clinical course of stress fractures. The initial diagnosis may be presumptive based solely on the history and findings of point tenderness or localized swelling. Days or weeks may pass before the fracture line or new bone formation becomes visible radiographically. Fractures involving the physis, the cartilaginous epiphyseal plate near the ends of the long bones of growing children, were originally classified by Salter and Harris and are commonly called Salter fractures. New bony material needed for the elongation of bones during growth is provided by specialized cells within the physis. When growth is completed, the physis transforms from cartilage into bone, ultimately fusing with the bone surrounding it and disappearing as a distinct entity. By definition, Salter fractures cannot occur in fully grown adults. Damage to the epiphyseal plate during a child's growth may destroy part or all of its ability to produce new bone substance, resulting in aborted or deformed growth of the limb. The potential for growth disturbance from an epiphyseal plate injury is related to the number of years that the child has yet to grow. The older the child, the less time remains for deformity to develop, and to the pattern of the fracture line through the epiphyseal area. An understanding of the short and long-term aspects of bone healing helps decision-making regarding fracture reduction, treatment modality, and the prognosis for regaining function or being left with residual deformity. Fracture healing consists of three phases: inflammatory, reparative, and remodeling, each of which blends into the next, with some degree of overlap between them. When a fracture occurs, the microvessels crossing the fracture line are severed, depriving the damaged bone ends of their blood supply. As a result, the bone ends gradually necrose, triggering a classic inflammatory response in which neutrophils, macrophages, and lymphocytes migrate to the area. The proteins and peptides, collectively termed cytokines, released by these cells promote revascularization. This early phase is brief but creates the tissue environment for the most predominant aspect of fracture healing, the reparative phase. Granulation tissue soon begins to infiltrate the area. Within the granulation tissue are specialized cells capable of forming collagen, cartilage, and bone, the ingredients of callus. Callus gradually surrounds the fractured ends and stabilizes them, becoming more densely mineralized with time. Meanwhile, the necrotic edges of the fragments are removed by osteoclasts, cells whose function is to resorb bone. That is why some hairline fractures do not appear on a radiograph until days after injury. Invisible initially, the diagnostic fracture line appears only after necrotic bone has been resorbed from the area. The final phase of bone healing, the remodeling phase, is the longest, sometimes lasting years. Remodeling is the tendency of bone gradually to regain its original shape and contour. During this phase, superfluous portions of callus are resorbed and new bone is laid down along the natural lines of stress. These layers, easily visible on radiographs of a normal bone, are the bony trabeculae. The formation of trabecular bone is a physiologically efficient process providing maximum strength relative to the amount of bone material used. The anticipated degree of remodeling after a fracture is related to a number of factors. Predictors of satisfactory remodeling include youth, proximity of the fracture to the end of the bone but not involving the epiphyseal plate, the amount of angulation, and the extent to which the direction of angulation coincides with the plane of natural joint motion. Some angulation near the end of a long bone, for example, may be more acceptable than the same amount of angulation near the midshaft. In the wrist, dorsal or volar angulation has a better prognosis than does ulnar or radial angulation because the natural plane of wrist motion is dorsal to volar. Mid-angulation in a 2-year-old child may be left to remodel on its own, whereas the same amount of angulation in an adult may require correction. Ortopedic emergencies include the following. An open fracture is a fracture associated with overlying soft tissue injury, creating communication between the fracture site and the skin. Although this term may convey the image of grossly exposed bone, the term is equally applicable to any puncture wound extending to the depth of an underlying fracture. Such puncture wounds may be created by external forces or may occur from within when a sharp bone fragment transiently protrudes through the skin before receding back beneath the surface. A potential major complication of open fracture is osteomyelitis. Once established, osteomyelitis may result in months or years of pain, disability, medical therapy, surgical procedures, and in some cases, amputation. Although osteomyelitis may sometimes be unavoidable, it is less likely when treatment is prompt and meticulous. Open fractures are usually classified by their severity based on the extent of overlying tissue disruption, lack of bone coverage, kinetic energy of the injuring force, and evidence or likelihood of significant contamination. Irrespective of these factors, any open fracture should be promptly and carefully treated. Subluxation and dislocation are also orthopedic emergencies. Subluxation is a condition in which the articular surface of a joint are non-concentric to any degree. Dislocation is the most extreme form of subluxation. A joint is dislocated when the articular surfaces of the bones that normally meet at the joint are completely out of contact with one another. The urgency of reducing a dislocation is based on several factors. One is the potential for neurologic or circulatory compromise. The neurovascular bundle passing close to the affected joint may become kinked around the dislocation. This may result in neurologic or vascular deficit that may be temporary if the deformity is reduced promptly, but irreversible if treatment is delayed. Another consideration is that the longer a joint has been dislocated, the more difficult it may be to reduce and the less stable the reduction is likely to be. This is probably due to, at least in part, edema, muscle spasm, and other tissue changes that increase over time. Dislocation of the hip also carries the potential for avascular necrosis of the femoral head. The necrosis occurs because much of the blood supply to the femoral head is delivered through vessels that emerge from the acetabulum. When the joint is dislocated, circulation to the femoral head is disrupted. At some point, the vascular insult becomes irreversible and bony necrosis results. Although a septic necrosis may occur despite the clinician's best efforts, its likelihood increases with the delay until reduction. Neurovascular injury is yet another orthopedic emergency. Any injury associated with neurologic or vascular compromise should be addressed as soon as possible. The longer such a deficit goes untreated, the longer it is likely to persist and the greater the possibility that it will be irreversible. In some cases, reducing a deformity by means of longitudinal traction is all that is necessary to restore circulation or nerve function. So when it comes to pre-hospital care, we need to splint the patient. Effective splinting of an injured extremity is important because it reduces pain, it reduces damage to nerves and vessels by preventing them from being compressed between the fracture fragments or being stretched by angulation at the fracture site. It reduces the chance of inadvertently converting a closed fracture to an open one if a sharp bone fragment pokes its way through the skin, and it reduces the pain associated with patient transport by minimizing the motion of fracture fragments. So there are many splinting modalities that are available to emergency medical service personnel. For injuries of the wrist or forearm, we consider using a sling to supplement the splint because optimal immobilization includes the joint above and the joint below the fracture, and the sling helps keep the elbow at rest. For suspected injuries to the shoulder, humerus, or elbow, a sling and swath arrangement works well. This method involves applying a sling, then binding the affected arm to the thorax with a gauze wrap. An exception to this principle is immobilization of patients with suspected anterior dislocation of the shoulder. Many patients with this injury have difficulty adducting the forearm, and forcibly binding it to the thorax may be painful. A simple sling is adequate in such cases. Injuries to the ankle may be immobilized in a pillow or well-padded cardboard splint. If a fracture of the tibial shaft or knee is suspected, the device should extend well above the knee to immobilize the joint above and the joint below the fracture. Some injuries also warrant special splints, such as a winch mechanism traction apparatus for femoral shaft fractures. Although such a device does not immobilize the hip, which is the joint above the fracture, the traction component makes this unnecessary. If a traction device is not available, then both the hip and the knee should be immobilized. One method of accomplishing this is to bind the legs together, then binding the patient to a backboard from ankles to thorax with folded sheets or towels beneath the lower legs, but not the feet, to ease pressure on the heels. There are also inflatable splints, and when you overinflate them, it may impair circulation. If the inflatable splint cannot be dented by moderate thumb pressure, it is probably overinflated. There are also non-malleable aluminum splints, but they're based on the one-size-fits-all principle, which some clinicians interpret as this size fits none. Malleable splints made out of aluminum are preferable to non-malleable ones since they can be made to conform more closely to the contour of the extremity, even accommodating some degree of deformity. If you use aluminum splints, you need to add pads to them because the hard surface may cause pressure sores. Another controversial device is military anti-shock trousers. This device may be used during ambulance transport of patients with already diagnosed pelvic ring fracture or for patients with a clinically apparent femoral fracture when a traction device is not at hand, since the device immobilizes the joints above and below the fracture. Many EMS programs do not recommend pre-hospital reduction of deformity for an injured extremity, as injudicious manipulation may convert a pure dislocation to a fracture dislocation. Even if a fracture had already existed, there would be no way to prove it was not caused by the manipulation. One circumstance in which pre-hospital reduction of obvious fracture to the shaft of a long bone may be justified is a non-palpable distal pulse. In the absence of a common standard, the indications for reduction of deformity by pre-hospital personnel remain at the discretion of the supervising EMS program. So, when it comes to the clinical features of fractures, the pain of a fracture or a dislocation may be referred to another area. Imaging is generally an important adjunct, but it is not the ultimate diagnostic resource. For example, patients with disruption of the sternoclavicular joint or fracture of the humeral shaft may only complain of shoulder pain. If the radiograph is based solely on where the patient reports discomfort, then the injured part might not be included on the film. Imaging decisions should be based not only on the chief complaint but also on systematic palpation, observation of subtle deformity or significant point tenderness, and mechanism of injury. Some injuries might not be radiographically apparent on the first day, regardless of what views are taken. Common examples are fracture of the scaphoid, non-displaced fracture of the radial head, and stress fracture of a metatarsal. The classic radiographic signs accompanying these injuries, such as the fat pad sign of the elbow, are not always conveniently present, but mechanism, history, and findings suggesting the injury often are. CT or MRI may allow early diagnosis of fractures that are not radiographically evident. However, these tests are not always available or feasible. Knowing the precise mechanism of the injury might be the key to diagnosing some fractures or dislocations. For example, a history of shoulder injury combined with the complaint of dysphagia may be the only clue to the existence of posterior sternoclavicular dislocation. This entity, which causes pressure on mediastinal surfaces, often can be demonstrated only by CT and may result in severe complications if treatment is delayed. There are other examples of mechanisms that may lead the clinician to suspect or presumably treat for specific injuries. For example, with a mechanism of bilateral compression of the shoulders, a possible injury is anterior or posterior sternoclavicular dislocation. In a direct blow to the medial clavicle, there is possibility of posterior sternoclavicular dislocation. On a fall landing on the apex of the shoulder, there may be acromioclavicular separation. On direct blows to the anterior shoulder, falling on an outstretched arm, seizure, or electroconvulsive muscular activity, there could be posterior dislocation of the shoulder. If sudden traction force to a toddler's arm is performed, there may be subluxation of the radial head, which is sometimes misdiagnosed as brachial plexus injury because of pseudoparalysis of the arm. On falls where there's landing on an outstretched arm or with the elbow beneath the body, there could be fracture of the radial head, which may be occult on initial x-ray. On forced dorsiflexion of the wrist, there may be fracture of the scaphoid, lunate dislocation, perilunar dislocation, and Colles fracture. When striking the knee against a dashboard in a high-speed collision, a possible injury is posterior dislocation of the hip. On landing flat on the feet from a height, there's a possibility of calcaneus fracture, tibial plateau fracture, acetabular fracture, vertebral compression fracture, and usually this is lumbar. On ankle inversion force, there may be fractures of any of the three malleoli or fracture of the base of the fifth metatarsal. On rotatory ankle force, there may be fracture of any of the three malleoli, disruption of the anterior tibiofibular ligament with a proximal fibular fracture, or Maisonneuve's injury. On inversion or medial or lateral stress to the forefoot, axial load on the metatarsal heads with the ankle plantar flexed, there could be midfoot dislocation, also known as Lisfranc's injury. Some musculoskeletal injuries or conditions may not necessarily be associated with a history of direct trauma. Occult fracture of the hip in an osteoporotic individual, acute stress fracture of a metatarsal in someone who has recently done an unusual amount of walking, and slip capital femoral epiphysis in a pre-teenager or young adolescent are examples of injuries in which symptoms may be gradual and insidious in onset, unrelated to an isolated traumatic event. Exquisite tenderness to palpation or pain on weight bearing or passive range of motion suggests the possibility of an occult or easily missed fracture. History taking should not be limited to orthopedic issues. And on physical examination, the essential components of the exam for musculoskeletal trauma are inspection for swelling, dislocation, or deformity, assessment of active and passive range of motion of the joints proximal and distal to the injury, palpation for tenderness or deformity, and assessment of the neurovascular status. When it comes to palpation, we have to do it systematically and consistently from one patient to the next. The area palpated should extend well beyond the location of pain described by the patient, as the pain may be referred. On inspection, gross deformity along the shaft of a long bone is pathognomonic for fracture. Deformity at a joint, loss of range of motion, and severe pain at rest suggest the presence of a dislocation or fracture near the joint. An exception is posterior dislocation of the shoulder, which, although intensely painful, might not be accompanied by obvious deformity, although the humeral head may be palpable posteriorly. So when it comes to neurovascular assessment, if the injury involves an extremity as opposed to the vertebral column, sensory motor testing should be performed on the basis of peripheral nerve function rather than nerve root and dermatomal distribution. In the upper extremity, the radial, median, and ulnar nerves should be tested. When the shoulder is anteriorly dislocated, two additional nerves, the axillary, supplying sensation to the lateral aspect of the shoulder, and the musculocutaneous, which supplies sensation to the extensor aspect of the forearm, should also be checked. In the lower extremity, examination of the saphenous, which is sensory only, peroneal, and tibial nerves should also be performed. The sooner circulatory compromise is identified and addressed, the better the chance of avoiding tissue ischemia or necrosis. So when it comes to imaging, the joints above and below a fracture should generally be imaged because injury at the proximal or distal joint may coexist with long bone fractures. First, a negative radiologic report does not exclude significant injury. Fracture of the radial head, scaphoid, or metatarsal shaft, for example, may be undetectable on radiographs initially, even when special views are taken. Second, the terminology used by radiologists to describe malposition of fracture fragments or disrupted joints often differs from the terminology used by orthopedists. Because the emergency physician may confirm with the orthopedist regarding the initial management of a patient, and because this interaction commonly involves describing the radiographic appearance of an injury, it is important that the two physicians speak the same language, so to speak. When describing radiographs in particular, although it's not a radio finding per se, whether a bony injury is open or closed is an important consideration and should be conveyed to the orthopedist at the outset. The implications of open fracture are of such significance that this factor alone may determine the patient's immediate care or ultimate disposition. For location of the fracture, typical reference points used by orthopedists to describe the location of a fracture along the shaft of a long bone are the midshaft, the junction of the proximal and middle thirds, and the junction of the middle and distal thirds. Any fracture more proximal or distal than these locations may be described in terms of its distance in centimeters from the bone end. When a fracture extends into the adjacent joint, it is termed intra-articular. Intra-articular fractures have special significance because disruption of the joint surface may warrant surgery to restore the joint's contour and provide subsequent prevention of traumatic arthritis. This feature of a fracture line, if present, constitutes important information. For orientation of the fracture line, the most common orientations are as follows: transverse, oblique, spiral, comminuted, segmental, torus, and green stick. Torus and green stick fractures occur almost exclusively in young children whose bones are more pliable than those of adults. Note the segmental fracture, which is commonly described incorrectly as a comminuted fracture. To an orthopedist, the term comminuted implies splintering or shattering. A single large free-flowing segment of bone between two well-defined fracture lines is a segmental fracture. The term displacement may be used in either of two ways. In the broadest sense, it pertains to any deviation from anatomic position or alignment. Used more precisely, displacement refers to the extent to which fracture fragments are non-concentric or offset from each other. The magnitude of displacement may be expressed in terms of direct measurement, such as a 4 mm displacement, or in terms of the percentage of the width of the bone. So, an example is 50% displacement or complete displacement. The direction of displacement is based on the position of the distal fragment relative to the proximal fragment. Dislocation, or rather displacement, should not be confused with separation, which is the distance two fragments have been pulled apart. Shortening, which is expressed in millimeters or centimeters, is the amount by which a bone's length has been reduced. Shortening may occur by impaction or telescoping of the fragments into one another, or by the overlap of two completely displaced fragments. The latter is referred to by some orthopedists as overriding. Because an radiograph affords no depth perception, a fracture that appears impacted on one view needs to be visualized at an angle 90 degrees from the first to differentiate it from a fracture whose ends are completely displaced and overriding. Angulation is described in terms of two parameters, degree and direction. Quantifying the angulation is relatively simple. One only needs to estimate the amount of unbending, expressed in degrees, that would be noticed to make the fragments parallel. Conveying the direction of angulation may be more difficult because the terminology is less consistent among clinicians. If there is a possibility of ambiguity in the description, specifying the direction of deviation of the distal fragment usually can resolve it. Depending on the anatomic area involved, direction of angulation may be expressed as anterior or posterior, lateral or medial, radial or ulnar, or dorsal or volar. Rotational deformity, that is, the extent to which the distal fracture fragment is twisted on its own axis relative to the proximal fragment, is generally not apparent on radiographs. This element of fracture description depends on physical examination. Its detection is particularly important in the phalanges of the fingers, where if rotational deformity goes unrecognized and uncorrected, the injured finger will permanently be malaligned when the hand is closed. Fracture combined with dislocation or subluxation occur when injuries near a joint may involve dislocation or subluxation combined with a proximate fracture. An example is fracture of one or more ankle malleoli together with partial or complete displacement of the talus from beneath the tibia. These are significant injuries, often requiring surgical intervention. If, in describing the injury, the clinician emphasizes the fracture component but expresses the dislocation or subluxation as mere displacement, then the full severity may not be appreciated by the orthopedist. Some injuries should be described as fracture dislocations or fracture subluxations. Like mentioned earlier, Salter-Harris fractures involve the epiphyseal plate. It's very unlikely for these to occur to adults. The easiest way to remember the Salter-Harris classification system is to think of those injuries not in terms of where the fracture line runs, but in terms of what has been broken off. Type 1 and Type 5 Salter fractures may be radiographically undetectable. Type 1 injuries usually involve no transverse displacement and little or no separation of the epiphysis from the rest of the bone. Also, the lucent fracture line is not visible within the equally lucent epiphyseal plate. Diagnosis of acute Salter type 1 fractures is usually presumptive based on the presence of swelling and tenderness in the region of the physis. Type 5 injuries may be evident only retrospectively when growth disturbance first begins to appear. At the time of initial presentation, however, a history of a significant axial loading force coupled with significant tenderness in the area of the epiphyseal plate should suggest the possibility of a type 5 injury. So when it comes to treating fractures, we control the pain and swelling. Even narcotic analgesics may have minimal effect on the pain of movement or manipulation unless combined with other CNS acting agents. So going back to Salter-Harris fractures, these are the types and what is broken off. In type 1, the entire epiphysis is broken off. In type 2, the entire epiphysis along with a portion of the metaphysis is broken. In type 3, a portion of the epiphysis is broken. In type 4, a portion of the epiphysis along with a portion of the metaphysis. And on type 5, it is a compression injury of the epiphyseal plate, so nothing is broken off. We also withhold oral intake because these patients may be candidates for prompt surgical fixation, manipulation, or other procedures under general anesthesia or procedural sedation. We also reduce the fracture deformity. So, the short term benefits to reducing deformity early include alleviating pain, relieving the tension on nerves or vessels that may be stretched as they pass along the deformity, eliminating or significantly minimizing the possibility of inadvertently converting a closed fracture to an open one when the skin is tempted by a sharp bony fragment, and restoring circulation to a pulseless distal extremity. When deformity is associated with circulatory deficit, a true emergency exists and the anticipated delay until reduction should be considered. We also reduce dislocations, and there are circumstances in which the potential benefits of a pre-reduction radiograph may be outweighed by the associated expenditure of time and money. So, a pre-reduction radiograph may be omitted in a patient with a history of multiple recurrent dislocations of the shoulder who presents with history, signs, and symptoms typical of another recurrence in the absence of significant trauma. So, when it comes to the initial management of open fractures, we administer antibiotics early to prevent or reduce the clinical consequences of bacterial contamination in open fractures. An accepted approach is using a first generation cephalosporin with the addition of an aminoglycoside when the wound is greater than 10 cm with severe soft tissue injury and loss of bone coverage. Some studies advocate the use of ciprofloxacin as an alternative to a cephalosporin. So when there is significant contamination by plants or soil, we consider the addition of penicillin or metronidazole, clindamycin, or vancomycin for penicillin allergic patients for anaerobic coverage. To lower the infection rate, not only antibiotics but also generous irrigation and adequate debridement are necessary to reduce bacterial contamination and colonization. The purposes of debridement and irrigation are to expose the wound in order to allow better identification of the limits of injury and facilitate inspection for foreign material, to identify and remove clots, debris, and non-viable tissue, and to reduce bacterial contamination and make the wound more resistant to the effects of any residual contamination. So, when it comes to orthopedic consultation in the emergency room, in cases of known or suspected compartment syndrome, we obtain prompt orthopedic consultation, and emergency surgical intervention may be required to try and avert permanent tissue damage and muscle contracture. If there's irreducible dislocation, then even with the aid of a nerve block or procedural sedation, this means that the dislocation cannot be reduced. And although technique is certainly a factor, there may be other reasons closed reduction cannot be accomplished, such as the interposition of soft tissues within the joint or the presence of an associated fracture. Circulatory deficit due to musculoskeletal injury warrants prompt orthopedic consultation. Even if circulation has been restored by the emergency physician through the correction of the deformity, the orthopedist may wish to investigate the integrity of the involved vessels and should at least be contacted to discuss the case. Some open fractures also need to be treated aggressively in the operating room. And of course, we also refer injuries that require surgical intervention. When it comes to the principles of splinting, the chemical reactions that cause plaster or fiberglass to set are initiated by contact with water. The higher the water temperature, the faster the materials harden. However, these reactions are exothermic, meaning that they liberate heat. The faster the setting process, the more heat is generated. Therefore, the temperature to which the skin ultimately is exposed will be the additive result of the water temperature and the heat released by the chemical reaction. For this reason, severe burns may occur when plaster or fiberglass has been immersed in mildly hot water, even though the temperature of the water itself would not be sufficient to cause such burns. Although there is no universally prescribed ideal water temperature, a safe practice is to make the water temperature not that hot, and if steam is visible, then the water is certainly too hot. To avoid irritation and minimize the potential for pressure sores, plaster or fiberglass dressing should include several layers of padding over the skin. When non-pre-padded longitudinal plaster splints are used, cast padding has to be applied separately. The padding does not necessarily have to be circumferential. Several layers of longitudinal padding will effectively protect the skin as long as they exceed the width and length of the splinting material. So, non-pre-padded plaster may also be used. When a splint is fashioned from plaster rolls, we determine the length of the splint by measuring out a single layer along the extremity according to the principles described previously. Then on a flat surface, unroll the plaster back and forth over itself to make a multi-layered splint. If fixed length plaster strips are used instead of rolls, then the only way their length can be customized is to shorten them, so an adequate length should be selected at the outset and trimmed as necessary. In either case, the splint should be at least 12 layers thick for an adult. Even more layers should be used for children who typically remain as active as possible and have little regard for protecting the dressing. When the dry splint has been prepared, we measure out several layers of padding over it, making the padding longer and wider than the plaster. The next step, which is oftenly overlooked, is to lay the splint on that surface and massage the layers into one another so that they fuse together. This creates a strong dressing that is solid on cross section. A splint whose separate fibers or layers are still visible on cross section is much weaker. And for immobilization devices, we have a shoulder immobilizer, we have a sling. These two are used for the upper extremity. You also have a long arm gutter, which is used for elbow fractures other than non-displaced radial head fractures and reduced elbow dislocation. Sugar tongs are used in wrist or forearm fracture. Short arm gutters are used for metacarpal or proximal phalanx fracture, with the ulnar gutter for the fourth or fifth ray, radial gutter for second index, or third, or also the middle ray. A thumb spica is used for scaphoid fracture, be it proven or suspected, and thumb metacarpal or proximal thumb phalanx fracture. Knee immobilizers are used for obviously pathologies of the knee, and posterior ankle mold, where we consider above the knee extension and or adjunctive use of ankle sugar tongue for unstable ankle injuries are used for ankle injuries. We also have ankle stirrups for simple acute sprain, hard-soled shoes for toe fracture, and short leg walking boots in which some toe or foot contusions or fractures where weight bearing is allowed. We also give motion and strength exercises for the different body parts that are involved. Adjuncts that can be used for immobilization or treatment or splinting of these patients include a pneumatic walking brace as well. And adjuncts to ambulation include crutches, which should be used by patients who can bear little to no weight on the injured lower extremity, and also there are walkers and canes. In the elderly or infirm patients in particular, they do not have the strength needed to use crutches safely. For them, a walker or a cane is more suitable. Unfortunately, these devices are more appropriate for partial weight bearing than for non-weight bearing conditions. Elderly patients who can bear no weight at all on an injured extremity may require initial bed rest or use of a wheelchair with subsequent rehabilitation. Complications that may arise from fractures include neurologic deficits from long bone fracture or joint dislocation. Recovery may take hours, days, or weeks. Sometimes the injury is irreversible. Vascular injury may also occur when peripheral vessels that run close to a joint sometimes are compressed or disrupted when the joint becomes dislocated, such as with the dislocation of the ankle or knee in the tibiofemoral joint. And compartment syndrome is also a concern. After a fracture or direct blow to an extremity, there may be extravasation of blood, swelling of muscle tissues, and impairment of venous flow within one or more fascial compartments. There are also delayed and late complications, such as pulmonary fat emboli that originate from the marrow of a large bone, such as the femur, and also, most delayed complications of fracture include non-union, malunion, which is healing with deformity, joint stiffness, traumatic arthritis, a vascular necrosis of the bone, and in the case of open fracture, osteomyelitis. Our source is Tintinalli's Emergency Medicine. Thank you.